of body image and eating disorders, acculturation, and racial ethnic identity development, as well as outreach to the campus community regarding psychological and wellness issues. Dr. An approaches psychological issues from the perspective that psychological development is affected by one's personal history and current environment. She enjoys helping individuals and communities identify strengths and resources that promote healthy development. Dr. An, welcome and thank you for joining us tonight. We're looking forward to learning more about the underlying emotional and psychological issues related to eating disorders. So without further introduction, I'm pleased to turn tonight's presentation over to you.
Thank you, Marty, and welcome everyone. And my presentation today is on understanding eating disorders and how to intervene. Just as part of my intro, as Marty has already said, that my expertise in working with college students and mostly adult populations. And I'm just noticing that everyone in the audience have a varying level of previous knowledge of eating disorders and from different professional and personal backgrounds and settings. So I'm going to try to cover a wide range, but some sections you may feel like it's going too quickly or some sections possibly too slowly, but I am trying to cover as wide range as possible. Okay, so let's look at the first slide here. So I want to just everyone in the audience to first privately just consider for yourself the following questions. When did you become aware of your own body image? What parts of your body are you happy, satisfied with? What parts of your body are you unhappy and dissatisfied with? And have you noticed any changes in your body image over the years and under different circumstances? And the reason why I ask everyone to consider these questions is that whether one actually has an eating disorder or some form of disordered eating, just everybody in our society is affected by various messages about body image, struggles with eating, and weight. So hopefully this self-awareness might help you to maybe better understand those you are trying to help, whether it's a family member or whether it's somebody in your professional field. Okay, let's go to the next slide. So eating disorders, I wanted to emphasize two main parts in my presentation. The first one is that eating disorders are serious, potentially life-threatening conditions that affect a person's emotional and physical health. And eating disorders actually has the highest mortality rate of all psychological disorders, including even bipolar disorder, schizophrenia. And the mortality rate we find in the studies is that it's both because eating disorders affect not only mental health, but one's physical health. So some of the deaths are related to the medical complications associated with eating disorders, but also there's a high suicide rate with this population as well, unfortunately. And then the second issue I wanted to really emphasize in my presentation today is that eating disorders are not simply about food and weight, but it's a way that the person is trying to cope with underlying emotions and psychological issues. And that's what I'll be trying to cover in our presentation today, to maybe better understand what may be some of those underlying emotions and psychological issues as we're trying to help those individuals struggling with eating disorders. So looking at the next slide, just some statistics for us to be aware of as you look at that slide about statistics among college students, girls, and then also the fact that predominantly we think about eating disorders mainly affecting women and girls, which is true, but approximately 10% of those suffering from an eating disorders are actually boys and men. And many people believe that it might actually be higher than 10%. It's just that boys and men don't come forward in seeking help because it's often thought of as a female disorder. All right, so let's go to the next slide. So some more statistics. Just in terms of how just one's body image might affect a person and how they interact with the world around them. So for example, in this Dove Global study in 2005 indicated that over 70% of girls avoid certain activities, so certain basic activities, because they feel bad about how they look. For example, giving an opinion, going to a social event, party, even going to see a doctor, or will be missing school as a result. Also, another statistic that I find really intriguing is the fact that in the U.S., eating disorders are more common than Alzheimer's disease. as many as 10 million versus 4 million. Yet eating disorders research funding is 75% less than that for Alzheimer's. So we really need a lot of advocacy in this area to be doing more research and advocacy and treatment. So let's go to the next slide. Now I want to put in this slide about some cross-cultural perspectives as we think about body ideals. This is a landmark study done in 2002 where researchers went to a section of one region of Fiji. So traditionally in Fiji, actually larger bodies were more valued, and they were seen as symbols of health and connectedness to the community. So when the researchers went in 1995, this was before they had television in this one region of Fiji, that there was only one reported case of anorexia. But yet, just 3 years later, after the introduction of television, 69% of girls reported dieting to lose weight. So just the impact of just 3 years of just media images on this population and how it can impact an entire community. Okay, so let's go to the next slide. Now, just to intersperse some of my slides with just some little facts or pictures to kind of help us think. And I'm very much of a visual person, too, so hopefully it also kind of splits up our presentation a little bit, too. So recognizing that a study found 3 minutes spent looking at pictures of models in magazines caused 70% of women to feel depressed, guilty, and shameful. And how many of us find ourselves looking at magazines, fashion magazines, just the type of magazines that are available, even in doctors' office waiting areas and school, different offices, and just the message that 3 billion women don't look like supermodels and only 8 people who do. Yet what are these magazines and these images telling people that we should be looking a certain way when it's just unachievable in reality? Okay, let's go to the next slide. And so I'm going to be starting with just talking a little bit more about different types of eating disorders, what they are. And so according to the DSM diagnosis categories, and DSM stands for the Diagnostic and Statistical Manual of Mental Disorders, this is the diagnosis tool that is used by clinicians, by therapists, psychiatrists. And so the 3 categories currently in the DSM is anorexia nervosa, bulimia nervosa, and then eating disorder not otherwise specified. And currently, binge eating disorder is categorized in that not otherwise specified category. It's very likely that in the next version, binge eating disorder is going to be actually a separate category on its own because we're seeing a very high percentage of individuals struggling with this particular disorder. Let's look at the next slide. So these are some behavioral signs of anorexia. So typically it's when an individual has a weight loss 15% or more below the ideal body weight. So typically you might see them restricting their eating. They might avoid particular foods, certain foods that they might categorize as bad. Typically it might be fats, carbohydrates. Even though they are hungry, they may have just become so used to denying that hunger that they're no longer able to have those natural signs from their body as to when they're hungry. And so they don't respond to their hunger. Even when they're starving, their body is starving. They also might use excessive exercising, not only restricting calories, but also excessive exercising to burn those calories. Anything they eat, they might try to get rid of it by over-exercising. And they just have a very intense, irrational fear of gaining weight, even though they're quite underweight and everybody else sees it, but the individual is not able to see it in themselves. And for those suffering from anorexia, how you can kind of interpret it is that they're turning away from food to cope. As I mentioned earlier, if we think about eating disorders as how an individual copes with the underlying psychological issues and emotions, that how these individuals are coping is that they're turning away from food. Now let's look at the physical and medical signs of anorexia. So there are many physical and medical signs, and some of them that I want to be able to highlight is amenorrhea. It's actually one of the DSM criteria is for the individual to have amenorrhea, meaning that they stop menstruating because they've lost so much body fat that they no longer produce adequate amount of sex hormones to be able to menstruate on a regular basis on their own. And the concern about this is that if they go through a long period of amenorrhea, they're going to start to lose bone mass. So therefore, we start to see early signs of osteoporosis in very young girls. I've worked with college students where they've already developed osteoporosis at age 19, 20. It's almost like their body is going into early menopause. You might also see, because they're lacking the nutrition for their body, that they're always complaining of being very cold. And in order to deal with the cold, what happens is that their body starts to grow fine hair on their body. You might see that on their arms, on their face. But they start to actually lose the hair on their heads because the nutrition isn't going to the extremities. It's trying to conserve it centrally in their bodies and the main organs. So now let's look at bulimia. So the behavioral signs of bulimia, typically, it's hard for us to be able to see an individual with bulimia and tell that they have an eating disorder, whereas with somebody with anorexia, it's quite visible because they're so underweight. With bulimia, they tend to be within actually fairly normal body weight, within 10 to 15 pounds of normal body weight. But the behavior that we might observe, or what they're engaging in, is they tend to binge eat, and then following the binge eating episode, they would be purging. And the form of purging can take many forms, including inducing vomiting, using laxatives, diuretics, excessive exercising. And they often feel very out of control of eating, and they're unable to stop once they start. They're usually overeating in reaction to some kind of emotional stress. A lot of sense of shame about their behaviors, and they do try to keep it very secret. To meet the criteria, the person would have to meet the criteria for bulimia, they would have to be engaging in this behavior at least twice a week for 3 months on average. And contrary to those suffering from anorexia, those suffering from bulimia, you can think about them as turning toward food to cope with emotional distress and the underlying psychological stressors. So now let's go to the next slide with physical and medical signs of bulimia. So if you look here, some of the main concerns that we have is for the electrolyte imbalance. Because they're purging, whether it's with laxatives, diuretics, induced vomiting, that they could have extreme electrolyte imbalance, which can lead to arrhythmia, heart failure. Sometimes we even have dentists actually be the first ones to identify a problem because they're having dental and gum problems, all the erosion in their gums and teeth because of the acid from the vomiting. They might complain of muscle cramps, GI problems, dehydration, and such. And let's go to the next slide. And now we'll look at binge eating disorder. So some of the behavioral signs, you can think about it as similar to bulimia, but without the purging aspect of it. So the overeating, sometimes they may alternate between restricting and then overeating, binge eating, usually nighttime secretive eating, and just feeling, once again, very out of control with their eating. And binge eating, to meet this criteria, on average, at least 2 days a week for 6 months. Now, for the next slide, looking at the physical and medical signs of binge eating disorder, usually it's those kinds of physical signs or medical signs that would be associated with obesity. So, for example, high blood pressure, high cholesterol, joint problems, diabetes, and such. So let's look at the next slide in terms of commonly co-occurring features of eating disorders. So first on that list is mood disorders. So that might include depression, excuse me, bipolar disorder. So when I work with students or clients with eating disorders, many of them are also struggling with some kind of a mood disorder. And then next on that list is anxiety disorders, including obsessive compulsive disorder or post-traumatic stress disorder, PTSD. So they often co-occur, and sometimes both depressive and anxiety symptoms I might see with eating disorders. And also just the obsessiveness of their calorie counting, calculating their weight, how much they've exercised. It can become a very obsessive compulsive component to their symptoms. And then the next commonly co-occurring feature is personality disorders. And then next is substance abuse and dependence. These co-occur quite frequently that we may not always think about, and especially for treatment providers, to really be aware that if we're treating only for eating disorders and they also have a tendency towards substance abuse, it's very likely that they're going to alternate between one or the other, so that if they're treated for one, they're going to develop symptoms in the other. We've seen this with some of our students. We had a student that we had sent in for substance abuse treatment, but because it wasn't a dual diagnosis program where they were addressing both the eating disorder and the substance abuse, she came out of the substance abuse treatment being clean of the substances, but then went right back to her eating disorder symptoms. Excuse me. And also when you think about, for example, when people who have had very severe kinds of medical procedures done, let's say like gastric bypass and such. For some, it can be very effective, but oftentimes what we find is that because they haven't dealt with the underlying psychological issues, afterwards they start developing other symptoms that are related to what might have led to their morbid obesity. And then another commonly co-occurring feature of eating disorders is self-injurious behaviors, meaning they might be engaging in self-harm behaviors like cutting themselves, burning themselves. So we often see that with many of my clients as well. And then lastly on the list is history of trauma or abuse. That could be sexual abuse, physical abuse, but also including bullying and teasing. So we have many who have had childhood history of bullying and teasing who have later developed eating disorders or distorted body image, and which could lead to developing eating disorders. So the next slide is from the Dove campaign, just that real women have real curves, so not only the models that we see in magazines with just thick, thin, absolutely perfect bodies, which are airbrushed, but that actually real women have varying body sizes, body shapes, heights, skin color, and such. And then the next slide. Here I put in quotes causes. I said, what causes eating disorders? Many people ask that question, and I put it in quotes because we don't exactly know what causes eating disorders, but I am able to talk to you a little bit about what are some possible risk factors that could lead somebody to develop an eating disorder, because some people may be in the same environment, and one person might develop an eating disorder, but the next person might not. So we can't say that there's an exact cause for eating disorders. But let me review some possible risk factors. So let me start with psychological factors. Often those who are at risk for eating disorders are those who are struggling with feelings of inadequacy, as I mentioned before, depression, anxiety, sense of loneliness, disconnectedness from other people. Many struggle with managing intense emotions and not knowing how to cope with emotions, express emotions, manage emotions. Feeling out of control, so therefore the eating disorders is a way that they feel they're able to control painful emotions. Things when the rest of their life feels so out of control, they might feel that their body's the only thing in their life that they can control. And so they might turn to it by either just eating all that they want without limit, or restricting and trying to control their hunger. Other psychological risk factors we often see that are related is perfectionism, believing that, okay, if I have this, it might be related to the body, and that's how it might manifest itself, but they often have perfectionism in the rest of their lives. They might have that tendency towards maybe how life has to be, how their grades have to be, how their relationships have to be, and have difficulty being able to recognize that there are no perfect things in life. And also a lot of competitiveness, meaning a lot of comparisons with other people and feeling that they need to work harder to achieve a certain goal. Lack of assertiveness, so they might have difficulty saying no or expressing their needs to other people. And as I mentioned earlier, the history of trauma or abuse and limited coping strategies. And then the next slide talks about interpersonal possible risk factors and interpersonal factors. So the first might be different kinds of family dynamics that might be unhealthy in the environment. And that might be that the parents are not supportive of the child's individuation, meaning that the child is especially hitting adolescence, wanting to be independent, wanting to explore, trying new behaviors, and the parents are not cognizant of that, not giving them enough flexibility, helping them go through that stage. Or there might be unhealthy boundaries, meaning that the parents are over-involved, under-involved, very controlling, or just no discipline, no boundaries. Or other things that I often see is that the food and weight issues are intergenerational. So I've had clients who have been struggling with an eating disorder, and when I start to understand a little bit more about their family and their upbringing and such, it's not very uncommon that I have had somebody else in their family who are also struggling, whether it's a parent, a grandparent, an uncle. I remember one student I worked with where she dreaded going and seeing her grandmother because her grandmother would be constantly critical of her weight. And so before she went to see her grandmother, she would be trying to restrict, try to lose weight. And it was very apparent that the grandmother was also struggling with her own weight. I had another student who was an athlete, who was a runner on the track team, and she was also telling me that her father runs a lot and is very obsessive with weight and exercise and such. So this isn't uncommon. Also, within the family, there might be family secrets, whether it's an abuse, affair, and that the individual is somehow trying to hold on to this secret or tolerate having to hold on to this secret through their use of food, their body. Another interpersonal factor might be a fear of rejection or actually having experienced some kind of rejection or loss. And those rejections or loss can be actual deaths of somebody close to them, or it could be a breakup of a relationship, a loss of ability. Maybe somebody had been in an accident, or I often see athletes, for example, who had been star athletes in high school, and then they come to college, and they've had some kind of an injury, they can't play anymore. It's an entire loss of sense of identity for them because that's who they were throughout growing up, that star athlete. And all of a sudden they're being benched, or they're no longer on a team and they don't have that sense of connectedness to the team. And they start to try to control something other than what they can control, and so therefore they might turn to their their body and their eating. Another factor might be avoidance of intimacy, whether it's emotional intimacy with somebody or sexual intimacy with somebody. And typically you see eating disorders developing a lot during different life changes and transitions, whether it's during puberty, when their body's changing, especially for girls, when they're starting to develop, either they're developing too early, too late, all the comparisons, the competitiveness with their peers. Separation, let's say, for example, many of them are going away for college for the first time. Some really struggle with that, and some are much more ready for it and have been wanting that. So independence, the relationship. I have so many students who are struggling, start to develop disordered eating and disordered body image concerns after a breakup. Because they can't make sense of why this person broke up with them. And so they try to come up with whatever would make sense, something that they can get a sense of control over, and they think, well, maybe it's the way I look, maybe it's my weight, maybe. And so they start to turn their attention and obsession into that. Also the childhood teasing and bullying, as I mentioned before. Many may have been teased about their weight, or sometimes not even about their weight. I've had students who said they were teased about how they were dressed or their hair, or yet that becomes all this focus on the body and somehow feeling that they were inadequate in some way. So next, social factors. All of us in our society, growing up in this culture, we know the media influences, we know the expectations, the pressures for thinness, to have that perfect body. Even though all those models in magazines are airbrushed, we think they're perfect, and somehow we should be able to achieve that, and we're less than if we're not able to achieve that. As I said, not only for women, but for men as well. Now, if you look at men's magazine, look at what's on the men's magazine covers, the six-pack abs, being muscular, being very lean. These pressures are becoming much more so for men also, not just women. And also because of the increase in childhood obesity rates, we've been talking much more emphasis on weight, about food and such, which is a very positive thing, because we don't want to be continuing to see increase in childhood obesity in our society, but also when we don't pair it with other kinds of things that are related to it, which I'll be covering later, like self-esteem, valuing other aspects of ourselves other than just how we look, that this could raise the risk factors for those individuals who could possibly develop eating disorders as a result. Once again, putting value on physical appearance rather than on an individual's inner qualities and their strengths. How do we judge a person? And this concept in our society, in our generation, of teaching our kids, you can be whatever you want to be. And I think this is meant to really boost their self-esteem, but it's also this mis kind of understanding for children growing up, thinking, well, if I can be whatever I want to be, and if I can't be this way, if I can't look this way, there must be something wrong with me. And then freshman 15, this is a particular risk factor for college students. Many college students have weight gain their first semester or for their first year of college for many reasons, whether it's the different abundant food and the buffet-style food in the cafeteria, whether it's them staying up very late, having pizza while they're studying, alcohol consumption, many calories from that, just staying up, the sleep, lack of sleep in our society, I also believe contributes to the increased obesity rate in our society as well, because what we've been finding is that sleeplessness also affects the hormone that tells us when we're full or hungry, and so that we tend to overeat when we're tired. So many students after their freshman year, that's typically when we see a higher increase in eating disorders, and many of them go on these crash diets, or they realize they've gained weight, and spring break is coming up, and summer is coming up, and they try to lose their weight quickly and go through drastic measures and start to develop eating disorders as a result. Also, there's this tendency in our society to look for quick fixes, whether that's a fad diet, some kind of diet pill, all those things in the ads, that tells you you can lose 50 pounds in 2 weeks, or cosmetic surgery, just parents giving their children cosmetic surgery, plastic surgery as high school, graduation gift. This sense that somehow this quick fix is going to help that person feel better, be happier, that message can be very misleading to the individual. Also, supersize me, that concept of all these fast food meals. Everything is supersized. There's no size small anymore. Everything is, medium, large, supersize. And so we have very distorted idea about what is a portion size, what's an appropriate portion size. Okay, so go to the next slide of biological and physiological risk factors. Dieting, this can really raise the risk of development of eating disorders, because what happens is that when we go on diets, when we try to deprive ourselves of certain foods, we're much more likely to crave it and to binge on it at some point. Also, when we go on yo-yo dieting, we may lose some weight, but we're likely to gain it right back, and possibly even more so, because it often leads to metabolism changes that our body is adjusting, and so it slows down the metabolism when we eat less. There's also some evidence that shows that abnormal amounts of there's abnormal amounts of various hormones in those with eating disorders, and it's hard for us to know at this point whether it's the cause or the result of dieting and the development of eating disorders. So we definitely need much more research on that. And we are starting to find that some research is indicating some genetic predisposition, so meaning through some twin studies, we're finding that if one of the twin has an eating disorder, the other twin tends to have a much higher percentage of also developing an eating disorder. So the next slide talks about family systems and risk factors. I mentioned a little bit about this earlier in the earlier section, but specifically about some family systems, either where the individual feels like they grew up in this perfect family, and so therefore nothing, no negative feelings, topics would be brought up, and so therefore the person has to just stuff in all their negative feelings and numb out all their negative feelings. And they might do that with food. Or there might be overprotective families where there's enmeshment in the family members. There's no sense of being an individual within the family. And then the child needs to continue to be dependent on the family. Or the chaotic family, where there's constant crises, either being too close, too distant, never a sense of that stability, predictable kind of boundaries, where often there might be some sexual abuse or alcoholism, ACOAs, adult children of alcoholics, meaning some kind of substance abuse in the family, or a lot of explosive anger within the family. And so the individual may have learned to turn to food to calm themselves during these periods. In the next slides, next couple of slides are about cultural and racial risk factors. Typically, we used to think about eating disorders mainly only affecting young, white, upper middle class women. But we're finding more and more that this is not the case. As I mentioned earlier, men comprise about 10% of all eating disorder cases, yet there isn't a whole lot of awareness about it or not enough research about men either with eating disorders. There tends to be a higher number of binge eating disorder in men, African Americans, Latinos, and those in lower socioeconomic class. And for the lower socioeconomic class, it tends to be related to just there being not as much access to healthy foods and exercise options. The age range is also widening. We tended to think about it more as in adolescence, early adulthood, but now we're seeing eating disorders starting from grade school, all the way into much older men and women. Some of our treatment centers, local treatment centers, they're starting to develop separate programs for women in their 50s, 60s, 70s, which that we wouldn't have really seen, 20 years ago. But we are seeing more women. And I remember even just recently I was at a buffet, and there were these group of elderly women talking about, their body and, how they just ate so much and feeling so bad. And I just don't remember a generation or two ago whether that was ever a topic of conversation. So we're seeing, as I said, a widening of this age range of where more are struggling with body image issues and eating disorders. Also, there's an increased risk among athletes, particularly in sports where there are weigh-ins. So whether that's in like wrestling, crew, where body size is important, like gymnasts, dancers, runners even. I have currently a student that I'm working with where she's finding that as she's lost weight, that she's running faster, and that's what the coach is really giving her kudos for that. And so it's really hard for me as I'm working with her as to how to see, okay, this might work temporarily, but what is it doing to her body? She's had multiple stress fractures, and eventually I'm really concerned that she might have some kind of a major injury as she's restricting eating and losing more weight, that she's going to have a major injury where she won't be able to run at all. But those long-term goals and risks are not often considered. Oh, and also one more comment about age issue is that I think also it's possibly because we're starting to, in our society, have less respect for elders, that there's such an emphasis and value put on youthfulness, and I think that's one of the struggles, and less value on the wisdom and the experiences of our elders. That puts more and more older men and women at risk too. So now let's go to the next slide. There's inconsistent findings about the prevalence of eating disorders among people of color. Some say there's less among people of color. Some studies say there's more. There may be some protective factors for women of color, but there tends to be a supportive community, a more extended family network, and also maybe different standards of beauty. For African American culture, for example, Latino culture, having a little bit of a hip and some curves is actually valued, and so that might become a protective factor. But there might be also risk factors for women of color because depending on their racial identity, the ideal beauty is based on white beauty. And so therefore, women of color are never going to be able to meet that. And so much of their body dissatisfaction is with their skin color, their hair texture, racial features such as eyes, nose, lips, and much of the plastic surgery that is done by women of color are to change those racial features, not so much, liposuction, let's say. And also the impact of when we were talking about trauma and abuse from childhood, the impact of racism, internalized racism, the trauma of racism and childhood racial teasing can put them at higher risk. So the next slide talks about don't weigh your self-esteem. It's what's inside that counts, and that's a message from National Eating Disorders Association. Then the next slide. The next few slides, just to kind of give you some sense of what the next slides will be, is that I have a few slides that are going to be more directed towards more treatment providers and clinicians and therapists, and then the last few slides will be more for maybe family members, school professionals, or others who may not be therapists, but in other roles where you can be still helpful to somebody struggling with an eating disorder. So specifically for clinicians, there's some cognitive behavioral approaches that might be helpful. For example, challenging cognitive distortions that the individual might have. The kind of all or nothing thinking, thinking, okay, since I ate that one cookie, I might as well eat the whole bag, and then I'll just throw it up. Or perfectionism, I have to be perfect in order to be liked, in order to be accepted. So helping the individual really challenge those cognitions and realize that they're distorted. Also helping the person give themselves self-nurturing statements versus punishing ones. They're constantly throughout the day punishing themselves and feel they're inadequate. So how to be able to slowly start to change those punishing self-talk in their mind constantly into more nurturing, self-nurturing statements. I also help individuals to really start to be more in tune with their body. So I say to them, scan their body throughout the day to see what are the hunger cues. Many of them have lost the sense of hunger cue and lost the sense of satiety cue as to when they're full, when they have eaten. So I might say, just scan your body to see how can you tell when you're hungry, what happens, what sensations. And then what sensations do you have when you're full so that they can respond more to their body's needs instead of emotional needs and external cues. Also help them change behavior to raise awareness, whether it's delaying a binge even by a few minutes at a time incrementally, or delaying a purge. So I would say just maybe, okay, if you feel you need to binge or purge, just wait 5 minutes and then do it. And next time maybe 10 minutes, 15 minutes. Or maybe change the binge food. If they tend to binge on, ice cream, maybe next time they, have them select something else. And just changing that behavior might bring more some kind of sense of awareness to them. Changing the schedule, so if they binge or purge every day, try to change it to maybe every other day, 3 times a week. Or changing the method. Instead of, eating something straight out of a bag, just pour it out, or and try binging with utensils, whether it's with a fork or trying getting those chips with a fork, or try binging with chopsticks or something, just to become aware of their behavior, because when they're doing it, it just happens more automatically, mindlessly. Maybe set an alarm so you're aware how much time has gone by that you've been binging. And then the next slide. I encourage my clients to keep a food feeling journal. So what I say is, before you have that urge to binge, just jot down for yourself, what are the thoughts, feelings? And if they're able to delay it and just write those things down, and if they still have to do it and they can't resist it, I tell them, okay, you don't have to stop yourself, then go ahead. But then maybe in the food feeling journal, write down what were their thoughts and what were their feelings afterwards. It's more for them to be able to make those connections, so that they're not doing it so automatically that it's not in their awareness anymore. And what I find is that the more my clients are able to do this on a regular basis, they may not feel that urge to binge or urge to purge as much, and they are able to delay it and postpone it and actually reduce it. The mindfulness, the mindful eating, as I said before, many of them just churn automatically to food, and they might be just binging. I had one client who said, every time she would have a phone conversation with her mom and she would be so upset, she would automatically just go straight to the refrigerator and just start eating. And so then they're not even thinking, okay, am I hungry, am I not? So when they're eating, I would just say things like, okay, notice the color of your food, the taste, the texture, temperature. And so it brings them to more the present being. Practicing relaxation techniques, that's muscle relaxation, deep breathing techniques, reducing the number of times one weighs oneself, incrementally decreasing or increasing the amount of exercise. If it's somebody's over-exercising, I might have them slowly start to decrease it. If they're under-exercising and they haven't really been involved in any kind of movement, I might say try something, maybe just 5 minutes, 10 minutes, maybe only once a week, a couple times a week. And also replacing it with a pleasurable activity as a reward for themselves. And making the binging, purging behavior inconvenient. That might be, growing out your hair or having jewelry that's going to get in the way, or keeping your hands busy by knitting. And then in the next slide, helping the person become aware that the body and the eating disorder is only one aspect of themselves, that it's not their entire being in their life. Helping them find other meaningful activities, relationships, roles in their life. Also taking responsibility for their behavior, so that if they have just purged, making sure they clean up. It's kind of, again, as I said, just bringing that awareness of their behavior, replacing the food that they've eaten. Thinking about their body parts, not just according to their appearance, but the function of the body part. I remember, being dissatisfied myself with my own stomach, feeling like, I remember in high school somebody made a comment to me that I had a pot belly. And ever since that, I had become so concerned about my stomach, sticking out, until when I became pregnant and had my baby, and realized, wow, my stomach is supposed to hold fat because it's supposed to be able to help me carry a baby and hold the nutrition that my child will need. And it just totally changed how I saw my stomach. So whether it's your legs or arms or whatever the dissatisfaction is, helping that person see the function of that body part. Training them in assertiveness. Also motivational interviewing. I do this quite a bit. So it's kind of recognizing the stages of change for them. That if they're at a stage where they're not ready to change at all, you can't go immediately into action stage, but to really help them think about what will be a motivation for them to change. It's not, if their parents brought them into treatment, okay, then they are going to have to find their own motivation for change. If they're only there because their parents have dragged them there, they're really not going to make use of therapy, and they're not likely to take any steps to change. So I try to ask them, if you are here, what would you like to change? It may not even have anything to do with food, actually. I was working with one student who absolutely did not want to deal with their eating disorder, and I said, well, what is it in your life that you wish were different? And she said, I wish I was happier. And so I said, well, what would make you happier? Do you remember times when you had been happy before? Okay, next slide. I'm having to move along a little bit faster because I'm running a little behind. Psychodynamic and interpersonal approaches to treatment. So helping the individual develop healthy attachments, and as I said, individuation, also developing trust in people, opening up to people, taking risks to develop friendships and close relationships. Learning to recognize. Many of them can't even recognize their feeling before they can express it. And also exploring what are their fears if they give up their eating disorders. Some of them, they've had some secondary gains, meaning I remember one student, they said, that's how all of my friends know me, as this person with this eating disorder, and that's how, I've gotten kind of their attention, their empathy, their sympathy. So she really feared what would happen to those relationships if she gave up her eating disorder. Explore issues of intimacy, loneliness, fears of their needs. Are they having an affair with their food? That they're so lonely that food is the only thing that is that unconditional safe place. Help them to start taking some risks to develop intimacy outside of that. Next slide, dealing with their defenses, whether it's intellectualizing, idealizing others, exploring the family dynamics. What was the purpose of the eating disorder? What purpose did it serve in the family? Maybe it was attention. Triangulation, meaning that, oftentimes I see a client coming in with an eating disorder, but it's actually that they are manifesting it as an eating disorder, but it's really some marital problem between the parents, and that child is getting attention through that eating disorder. It's bringing the parents together to care for their child. Maybe an expression of anger, that they're not able to express anger, and so therefore they're expressing it through restricting eating or refusing to eat. Where did you learn that you're so bad? And maybe it's a self-punishment. Exploring obesity as a body armor. I've had some students who talk about that because of their abuse history. It's like, okay, if I'm big and if I make myself unapproachable, unlovable, that is how I'm going to keep myself safe and protect my body. Next slide talks about just different levels of care options. So when you think about where the individual is, for us to think about what is the level of care that is optimal for them. I always say start with prevention. That's the best treatment, first of all, because of cost. It costs the least. And also often because eating disorder treatment is so difficult and prognosis isn't always good, especially if somebody's been struggling with an eating disorder for many years. Then the prognosis and the treatment is much more difficult. So prevention, raising awareness, education early on, early age, developing healthy coping strategies, and high self-esteem. If somebody does have an eating disorder, start with outpatient treatment and needing to pay attention to the medical needs and nutritional needs. And it has to be tailored to the individual. And depending on the severity of the eating disorder, it might be weekly outpatient therapy. It might have to be more intensive, maybe several times a week, or maybe even an outpatient 3-4 days a week at a hospital. And then when it does become more severe and life-threatening, the individual might have to be hospitalized and medically stabilized first before you can even do any kind of therapy with them. Next slide. Modes of treatment. I say this disorder is something that needs to be treated by an interdisciplinary treatment team. So within an interdisciplinary treatment team might be a therapist who does both individual counseling, but group counseling is also very important because there's so much of an interpersonal aspect to eating disorders that the individual learns a lot in group therapy about how to take risks, how to be assertive, how to connect, how to build trust, make attachments, and also family therapy because, as I mentioned, there's often a lot of family dynamics that need to be worked out. A psychiatrist, because many may need to be evaluated for possible medication. Medical professional, definitely, as I said, because of all those medical complications that are associated with eating disorder, somebody needs to be, a medical professional needs to monitor them. Maybe an exercise consultant, depending on whether they're over-exercising or they're not doing any kind of movement at all. And then also a registered dietitian who can really help them with the nutritional choices and helping them to be able to not only just information, but that they might have certain foods that they're really afraid of or that tends to be their binge trigger foods and how to manage those anxieties around that. Okay, so the next slide just says, your body is the vehicle that will carry you to your dreams, so honor it, respect it, and fuel it. And the next few slides, if you're a family member, a school professional, or somebody else in an environment where you want to be able to help and not as a clinician. So first of all, educate yourself, and this is what you're doing by attending a webinar like this, so knowing the warning signs. And be conscious about just promoting a healthy environment, whether it's in your home, in the school, in the community, in the church, wherever it is. So being a good role model yourself of healthy body image. Choose to talk about yourself and others with respect and appreciation, not just about how they look, but about their goals, accomplishments, character. Avoid judging yourself and others on the basis of body weight. I have many clients who, they grew up hearing their mother always just be decided that it's not that their mother criticized them, but they always saw their mother being criticizing her own body. And so then the child grew up feeling, oh, well, if she feels that way, maybe I should be thinking about that, and maybe I look the same, so I must have a problem too. Or categorizing food as that's good food or bad food. We all need variety, and once we start to categorize, once again, it becomes those cognitive distortions of all or nothing. So, oh, I've eaten bad, so therefore, I need to do this. Be a critical viewer of the media and its messages. I have, many different video clips I had wanted to share, but because of limited time, I wasn't able to include that in the slides today. If you're concerned about somebody, express your concern forthright in a caring manner directly to that individual instead of talking behind their backs. Oftentimes I've had students, roommates who have come, and everybody on the floor is talking about this individual, and they usually sense it, and so they become even more secretive and very defensive. Consult with a professional if you're not sure what steps to take, maybe with a school counselor, psychologist, or family physician. Next slide. First of all, determine if it's an emergency. If it is an emergency, you need to get them immediate help, or even call 911. If they're fainting, coughing up blood, talking about suicide. If it's not an emergency, as I said, talk to the person directly. That's most respectful and most effective. Try to choose a time and a place where both of you are comfortable, you won't be interrupted, you won't be in a rush, when you're feeling calm, not when you're upset, and use I statements versus you statements. Instead of these accusatory, you just need to stop that. Say, I'm concerned. I'm afraid that I'm really nervous as you're doing this. That what will happen? Express your care and concern and your desire to help, and help them to seek professional attention. But one thing I say is try to avoid labeling it as an eating disorder, because especially for those who are really in denial about it, that's going to close them up and shut them down immediately. But maybe say, I'm really concerned about you. I've been noticing changes. Next slide. Talk to that person to, encourage them to explore those concerns with the professionals. And if you're a parent, obviously, or, if it's a minor, obviously you might have to accompany them, make those appointments. If it's an adult, offer to help them if they need that assistance. They can also have multiple entry points. So maybe they won't be willing to go to see a therapist, but maybe they would be more willing to go and see, a nutritionist. But try to make sure that it's a nutritionist who is aware of eating disorders and specializes in that. Next slide. Avoid getting into an argument. Maybe pause if they're defensive, they're not answering, maybe say, just think about it and maybe come back to that conversation at a later point. Next slide. Do not become their therapist, savior, victim. Do not try to control that person, what they eat, what they do, because they're already struggling with issues of control. And so if you try to do that, they're just going to turn away from you more, and they're going to try to be even more secretive. But really being supportive of them, being patient with them, helping them to identify the reason why they would want to change. As the next one says, try to see what would be their reason for wanting to change. What is not working for them now? Many of them, it's like they realize they're thinking about it way too much. They're not able to concentrate on their studies. They are not going out, making friends. Maybe it's that they don't have the energy to do something that they used to love to do. So capitalize on those kinds of things. Help the individual to really think about what would make them happy, or what used to make them happy, because once they've developed an eating disorder, oftentimes they aren't able to. Encourage them to try something new that they've put off. Encourage them to try some kind of enjoyable movement, not just exercise, but maybe it's dancing or yoga or Wii games, and join them. Help them to discuss feelings rather than focusing so much on what they're eating, their weight, their calories, and such. And also, trying to help somebody with an eating disorder can be very straining on the person who's trying to help. So you might want to get some consultation and support for yourself as well. And then refer to the resources at the end of this presentation for more information. There are many websites with further information. So this slide just says that 6% of girls say that their primary role model is their mom. And so just having any kind of positive female role model, whether you're a teacher or a counselor, whoever it is, to help them build healthy self-esteem. Right. And then these are the resources that I was referencing earlier that you're able to go to websites. The GERS books is actually all books on eating disorders, so that's a great resource. And then the last three are more things that the individual can go to, you can go to. It has a lot of just different healthy information, self-esteem information, and such. All right, I know I moved through those last few slides very quickly, but I will now open it up to questions and any comments.
Dr. An, thank you. A lot of great information. And I'm going to jump right into the questions that we have, okay? Can you hear me okay?
Yes, I can.
Okay, good. One of the statistics on your slides about ED said that it has the highest mortality rate of all psychological disorders. That was disturbing. I mean, could you just talk about that a little bit?
Yeah, as I said before, it is because eating disorders are not just mental health issues, but there's many medical complications associated with it. So these disorders are very serious, and it can cause death. Anorexia, where they become so underweight that their organs start to fail. Even bulimia, actually, people think that that's of a less risk, but that's not true. Even after one purging episode, their electrolyte imbalance can go low so quickly that they could have heart failure and die instantly. But as I mentioned, it's not only related to medical complications, but also we're finding that there's a high occurrence of suicide rate as well. I believe because, as I said, it coexists with depression and anxiety, which also are commonly related to suicide risks.
Yeah, well, that was just striking when I saw that. So, given that question, it leads me right into the next one. So why do you suppose there's such a lack of funding for this, especially given the number of affected individuals?
It's really hard to tell, but we do find that, I mean, one thing is that I think we used to think about it as more of a women's disease, and just historically, I think many women's disorders just haven't had the priority as other conditions. So I think that's one aspect of it. Yeah, and then I think we think about it as affecting a very small population, which that isn't the case. That's why many of these eating disorders national organizations are really working for advocacy on Capitol Hill and with legislature to change, to bring about more research and more treatment opportunities, because many insurance companies won't even cover. This is what I run into a lot with my clients, where insurance companies won't cover treatments where, let's say, for example, they are going inpatient. They would only cover for a very limited time, so that they come out and they relapse and they have to go back right in. And so ultimately it costs insurance companies more money, yet they don't see that.
Yeah, yeah. Wow, and that's just surprising given the number of cases and then your comparison there to Alzheimer's, which was really striking. Wow. Could you elaborate a little more on the mindfulness techniques? How would a parent work with their teenager using mindfulness as a tool?
Yeah, mindfulness techniques are, it's been used with many different things. I even try to use it with students regarding emotions, depression, anxiety. It's partly helping the individuals be just present in the moment. So for example, if they're struggling with an emotion, it's about understanding, okay, it's an emotion, just observing it, noticing it, not judging it, not trying to get rid of it, but just noticing it and also noticing that it will pass. So that they're not numbing it out, stuffing it with food. So that's one aspect of it. But also mindfulness in terms of eating. We do a lot of mindless eating. We might be sitting in front of a TV and eating. I had one student who said that was they had no meal times at home, and so she would just sit in front of the TV and just eat, and so she would be struggling with binge eating because she wouldn't even know that she's full. She's just mindlessly eating. So therefore, I would just say, okay, with any kind of food, just pause and taste it, feel it, just training them as they're eating, slowing things down, noticing. And as they do that, they're much less likely to binge and overeat.
Well, you kind of have to not eat the ice cream out of the container, I guess.
Right.
Probably a good place to start, yeah. But, you know, which is another point, too. You look at what's on packaging in terms of calorie count. It's so related to portion size, and yet portions are out of control. You know, it's out of control what you get when you go to a restaurant even.
That's what I was thinking. I traveled to Korea last year, and I just realized I wasn't even aware, like even drinks. They're almost like half the size of the sodas here. I mean, of course they have the regular size sodas in Korea as well, but like juices or Korean drinks, Korean-made drinks, they're half the size. Whereas here, sodas, you know, everything just is in such large bottles, cans, you know, and we don't even realize how much we're eating. And we just think that once we open it up, we think we have to finish it.
You got to finish it, absolutely. The starving kid somewhere is how I grew up, yep.
And parents would also say you have to finish that food, and so they're not able to respond to their hunger cues and their satiety cues.
Since we are the Tourette organization, I'd like to touch briefly on weight gain associated with medications that some kids with Tourette, as well as kids with other neurological issues. But there are definite medications that induce and bring on a weight gain. So could you discuss a little bit how a parent can support a child taking a medication with that side effect?
Sure, yeah, and this is very difficult because I also have clients who are taking medication for, let's say, depression, and there is, as a side effect, weight gain. Sometimes, I mean, I'm not a medical professional, I'm not a psychiatrist, so I would say really, first of all, consult with, excuse me, a medical professional or a psychiatrist. But it is true, having to acknowledge that some of the medications are going to lead to weight gain. So just as with any of the other things, suggestions that I gave, helping that person, just making better food choices, whether it's portion size, encouraging them, supporting them, just movement, as I said. For example, I know a client that she's on medication and she's gained quite a bit of weight with it, but she just tries to compensate by exercising more regularly, and just portion size, even food selections. I would say even working with a nutritionist, I think would be helpful situations as well.
Are you okay?
Yes. I'm tickling my throat, sorry.
That's right. Could you've had a number of questions from teachers or school counselors, or in another case, a college counselor, about how to work with what do they do, and how, you gave some good examples in your presentation. Could you talk a little bit about that? Because I think it's important that the teacher or the counselor who doesn't have a lot of experience in this area doesn't turn somebody off and push them away, because if they think someone's at risk, you really want to be able to help.
Yeah, I do a lot of training for interns on eating disorders as well, and I think many are very afraid because if they're not familiar with eating disorders, they think, well, I don't really know how to treat somebody with an eating disorder. What I say is, if you're already a clinician, a therapist, a generalist, you already know all the skills that would help them. In terms of, obviously, there's specific information about eating disorders you need to know, which I've shared today. But if you think about it as a coping strategy that they're using, most people are engaging in some kind of unhealthy behavior that they're coming to counseling for, whether that's using substances, whether that's, their unhealthy sleep habits, maybe, internet addiction, whatever the case may be. But thinking about it that way, so helping them really develop other healthy coping strategies, I think is really important, and addressing those underlying issues rather than just about the food and the eating, the weight part of it. And so helping them connect it back to what are the triggers, what are some healthy ways that they can cope with and express those emotions.
All right. Are there services for a child in public school with an eating disorder that parents should be aware of, that you're aware of?
Well, unfortunately, because I work in college setting and with adults, I'm not as familiar with children, but definitely consult with the school counselors, school psychiatrists, psychologists to ask about services. There are many treatment centers that provide services for children, but specific to the schools, I think you would need to consult with the individual schools.
Okay, you're right, and I actually forgot that you deal more with the adult population. I had a question about dopamine and what role that might play in binge eating disorder. Could you comment on that?
Yeah, unfortunately, I'm not too familiar with the specific medication, because dopamine and all of that, serotonin, it would have more to do with psychiatrists who are dealing with the medications. That's not an area of expertise of mine, unfortunately. Sorry about that.
Okay, no problem. Let me see what else we have. In fact, we've run over quite a bit, so I think I'm going to make this our last question. What is the latest information that you know of about pica and, eating disorders that are non-food eating disorders?
I wonder if I can get more information, more details about what the person might be asking.
No, it was really just what's the latest information on that. But if you like, I'll be happy to put that question on the chat board, and then if you wanted to, cover that in a little bit more detail, that seems fine. Then I'm going to slip one more question in then.
All right.
Could you speak a little bit about enabling, by the extended family, and the importance of getting everybody on the same page about eating issues in a family?
Yeah. I think enabling can happen as I think I mentioned in one of the slides about, for example, having the individual take responsibility for their own behaviors, especially if it's binging, purging behavior, for that person to be able to take responsibility for the cleanup, replacing the foods, having them, some may also avoid, or the family might schedule their entire meals or everything else around that individual. And so there are some accommodations, of course, you want to make, but I think when you do that, you might also enable that person to continue in that unhealthy behavior. If they're working with the therapist, first of all, if you can get them started working with the therapist, I think consulting with the therapist as to where are the boundaries that you can set, what will be a healthy boundary, because each individual is going to be so different. So working closely with the therapist, hopefully in family sessions, to talk about what is enabling for that individual and what is being supportive and helpful. I think that would be important to determine.
Okay. And you know what? I'm going to take that back. I have one more question because
Okay.
this questioner has asked, really pleaded that you see if you can tackle this, and if you can't, maybe you can cover it in more detail on the chat board. But it has to do with this adult who has Tourette and has also eating disorders. And so her question is there any kind of statistical information on Tourette and eating disorders and the incidence of those?
Yeah, unfortunately, that's not an area that I'm familiar with. Yeah, so I won't be able to answer that question. There are a lot of, as I said, comorbidity with co-occurring with different anxiety disorders.
And OCD certainly.
Yeah. But I haven't seen, I don't remember seeing anything, any statistics or anything with Tourette's specifically.
Okay. So in your research and the work that you've done, nothing, has really jumped out at you in terms of statistical information combining Tourette and eating disorder then?
Yeah, nothing that comes to mind at this time, yeah.
Okay. All right.
I'll be happy to, I'm on this different listserv, so I'll be happy to maybe pose it to some of my colleagues and be able to get back to that person if I find any additional information.
That would be perfect. Then we can certainly post that question on the chat board, and if you could, provide some additional information there, that would be great. Okay. Dr. An, thank you. I think I really am going to keep my promise now. That's the last question. So thank you very much. Great information. Thank you so much for hanging in there. I appreciate it.
Thank you.
Good night.
Thank you all for joining our webinar on understanding eating disorders and how to intervene. There is an exit survey which we need everyone to fill out. This discussion board is open now and is available for the next 7 days on the NJCTS website for any additional questions that were not covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to the site. Our next presentation, the Tourette Syndrome Impact Survey, Recent Findings and New Directions, is scheduled for June 27th, 2012, and will be given by Dr. Kathy Budman, a leading researcher in Tourette Syndrome. This ends tonight's webinar. Thank you, Dr. An, for your presentation, and thank you, everyone, for attending. Good night.